Good morning, everybody. My name's Graham Hart. I'm Professor of Sexual Health and HIV Research here at UCL, and I'm here today in my capacity as Director of UCL Health of the Public, and I'm delighted to welcome you today to our 5th annual symposium, which is being held in UCL's bicentennial year. So Health the Public was developed as a consequence of the Academy of Medical Sciences report, Improving the Health of the Public by 2040. And the report recognised that public health problems can't be solved through biomedical sciences alone because they're so influenced by social, economic, environmental and behavioural determinants. And these fall outside the scope of traditional biomedicine. So our role across UCL during the past 5 years is to create a number of communities of interest, mainly from faculties outside of the life and medical sciences. So we're really powerfully trying to engage with all 11 faculties, but particularly those outside the biomedical sciences. We've recently been incorporated into the Vice Provost Health Office, and that will allow us to even more strongly relate to the 11 faculties across the university. So we have a number of communities and groups that we support. We have early career researchers, and I'll be saying something about that later. But just a quick plug here. Something you really should listen to is Public Health Disrupted, which is our podcast, which is in its 6th season this year. And it is hosted by Zand van Tulleken and Professor Rochelle Burgess. They have a great chemistry. We have superb guests, and it's always really fascinating. And in fact, because of the 200th anniversary of UCL, we're going to have a special live audience recording of Public Health Disrupted at the Bloomsbury studio, and in that we'll be actually reviewing the 200-year history of public health at UCL. So I'm delighted to see so many people here today, and we have also a lot of people online. In fact, we've had more registrations this year than in previous years, so it's a real success for us, we hope, and we hope that you'll enjoy the day. The symposium focuses on the government's 10-year health plan for England, which aims to deliver better care for patients, and the three pillars of that new approach are from hospital to community, from analog to digital, and from sickness to prevention. And it's the last of these that we'll be really focusing on during today's presentations. We're, of course, joined by colleagues from UCL, but also some external guests, including colleagues from the University of Edinburgh, Department of Health and Social Care, and very delighted to welcome the Head of Children, Young People and Perinatal Mental Health at NHS England. So we're not expecting any fire alarms today, and in the event of an emergency, please follow the instructions of the team here at the venue. And you can see the fire exits at the back, and there's an exit here as well. For those of you who are online, we'd encourage you to submit any questions you have for our speakers and panelists via the Slido link in your joining instructions email. So without any further ado, I'm delighted to introduce you to Dr. Oliver Mytton, Public Health Consultant and Associate Professor here at the Great Ormond Street Institute of Child Health. And Ollie's going to chair our first session, Turning the Tide on Obesity. Thanks, Ollie.
Thank you, Graham. I'm delighted to chair this session today, Turning the Tide on Obesity, which speaks directly to today's focus on prevention. Obesity, as many of us know, remains one of the most complex public health challenges we face, and it affects health across the life course. Whilst obesity is often framed in terms of individual behaviours, as I'm sure we all know, the evidence shows a different picture, but it's shaped by wider structural and environmental factors. These include the wide availability and heavy marketing of cheap, highly palatable and unhealthy food, as well as other factors, urban design, working patterns and socio-economic factors. UCL, I'm proud to say, plays a leading role in obesity research, both through the NIHR Healthy Weight Policy Research Unit that I chair with my colleague Clare Llewellyn, as well as the UCL Biomedical Research Centre obesity theme. But obesity research at UCL is much broader than this, as Graham has alluded to. UCL can draw on expertise across public health, nutrition, behavioural science, economics, urban design, and many more. So obesity is not a problem any one discipline can solve. And in this session, we'll hear from 4 researchers who are each going to showcase some high-quality research that speaks to these themes and issues, but also high-quality research that is informing practice and policy today. So I'm looking forward to a lively discussion and an excellent set of presentations. So let's begin with our first presentation, and this is Rachel Allen. Rachel is Joint Team Leader for SACN, which is a Scientific Advisory Committee on Nutrition at the Office for Health Improvement and Disparities, or OHID, which sits within the Department of Health and Social Care. And Rachel is going to talk today on dietary risk factors, their monitoring and role in developing policy. So Rachel, please come forward.
Hello, can you hear me? Yeah. So yes, I'm one of 2 Rachels. Rachel Elsom and myself head up the Scientific Advisory Committee on Nutrition Secretariat at the Department of Health. So today I'm going to talk about UK government dietary recommendations, a summary of the evidence on ultra-processed foods and health, and an overview of UK policy relevance. So I should say, as I'm going to be talking about UPF, I don't have any conflicts of interest to declare. So hopefully you're all familiar with this. This is the government's UK Eat Well Guide. So government dietary advice on a healthier and more sustainable balanced diet is encapsulated in the UK Eat Well Guide. And this is based on evidence provided by SACN in various SACN risk assessments. So it's important to remember that the evidence to support UK dietary guidelines needs to be robust and stand up to legal scrutiny. So SACN is a committee of the Department of Health. It provides independent scientific advice on nutrition to the 4 UK governments with a focus on public health rather than clinical issues. It has a focus on risk assessment only, so not risk management or setting policy, only if asked specific questions on risk assessment. So it works to a framework for the evaluation of evidence, prioritising evidence from good quality randomised controlled trials over observational evidence. Members adhere to a code of practice for government advisory committees, and risk assessments are based on transparent, robust scientific approaches of the best available evidence. So at the moment we have 18 full members, and membership's in line with the public appointments process, so we advertise and recruit through open competition, and members declare any interest in a register. And actually, SACN's policy on interest was updated in 2025 that states that individuals are only eligible to become SACN members if they don't hold significant interests in relation to food, drink, diet, or supplement industries. So any conflict of interest are declared and managed. For example, individuals with a conflict would be excluded from discussion on a topic, and that's in line with the code of practice. So even though SACN doesn't set policy, it has a far-reaching impact. So as an example of SACN recommendations set in 2015 in its carbohydrate and health report, it included the recommendation that free sugars should make up no more than 5% of calories. And this has gone on to impact many policies, including the soft drinks industry levy, calorie reduction, and the more recently published consultation on the updated nutrient profile model, the NPM. So the impact might be seen over a number of years. So in 2006, SACN recommended fortification of flour with folic acid, and more recently it was asked to provide advice on monitoring of the impact of fortification. So just looking at processed foods as an example of SACN's work, to give a bit of background, on processed foods, NOVA, you're probably all familiar with the NOVA classification, it's the most commonly in research definition of processed foods, and it includes the definition ultra-processed foods. So the NOVA 4 category ultra-processed foods is estimated to make up about 50 to 70% of the food we eat, depending on the population group. And because the definition is imprecise, it makes it quite difficult to reliably estimate how much we are consuming. So we're really interested in the World Health Organization work that's been carried out at the moment to look at an operational definition. So the UPF definition, as you might expect, is based on the level of processing and not on the nutrient content. Therefore, so there are some foods that we would consider to be healthier that fall under the category of UPF, such as higher fibre breakfast cereals and lower fat yogurts, and some foods that we would consider healthier, such as butter and homemade cakes that wouldn't be considered UPF. So there is overlap between HFSS and so foods that are high in fat, salt and sugar and UPF, but it's not complete. So SACN's most recent review of the evidence on processed foods and health was published last April in 2025, and it looked at the rapid evidence update on ultra-processed foods and health. So at the time of publication, one key trial had been published, and that was the 2019 trial by Kevin Hall et al., but a few more trials have been published since, including here at UCL, and there are more in the pipeline. And at the time, SACN reported that the majority of umbrella and systematic reviews found that increased consumption of UPF was associated with increased risk of health outcomes, including obesity, type 2 diabetes, cardiovascular disease, cancer, and mental health conditions. However, subgroup analyses from prospective cohorts suggest that not all UPF categories have the same impact on health, and poor health outcomes tend to be associated with specific food categories, including processed meats, sugar, and non-sugar sweetened beverages, and SACN's already made recommendations in relation to these foods. So SACN concluded that on balance, most people are likely to benefit from reducing their consumption of foods high in energy, saturated fat, salt, free sugars, and low in fibre. And SACN made a number of recommendations to government as well as research recommendations and is keeping a watch on the evidence. And we have a Horizon Scan meeting this June where SACN will have a look at the updated evidence. So how does this relate to policy? Government dietary advice is based on long-standing advice from SACN that diets high in energy, saturated fat, salt and sugar, or HFSS, low in fruit and veg, are known to be associated with increased risk of obesity and disease. And the UK Eat Well Guide already shows that many foods classified as UPF are not part of a healthy balanced diet. So the NHS pages have been updated in line with SACN's recommendation. And SACN recommendations on processed foods align with existing policies, given the overlap between HFSS and UPF. Around 60% of UPF consumed in the UK are classed as less healthy under the current nutrient profile model. So the updated NPM improves alignment and supports SACN recommendations. There may also be unintended consequences of people switching to minimally processed foods or reducing UPF, such as people choosing butter and sugar over fat spreads and sweeteners, and reducing fortification in search of a clean label. So government policies, therefore, remain focused on supporting the public to reduce consumption of foods and drinks high in energy, saturated fat, salt and sugar, where there is stronger, more established evidence base. So I think it's a positive shift that the UPF concept has engaged people into thinking about the quality of their diets, and processing may add another dimension to the quality of their diet. But while we wait for more good quality RCT evidence to emerge on the mechanisms behind this, the policy focus remains on reducing consumption of HFS foods. And this work is progressing through government policies, including restrictions on the advertising of less healthy food or drink products on television before 9 p.m. and all paid-for advertising online, volume price promotion restrictions or less healthy food and drink in stores and their equivalent places online, the soft drinks industry levy, a commitment for all large businesses to be mandated to report against standardised metrics on healthy food sales, and the updated nutrient profile model that I mentioned to be used to determine which foods are less healthy within promotion and advertising restrictions. And the consultation has just recently been published. Other government actions include the UK's new food strategy, a commitment to review school food standards to reflect the most recent government dietary recommendations, and publications of the voluntary industry guidelines for commercial baby foods last year. So just to conclude then, government dietary advice is based on robust risk assessments carried out by the Scientific Advisory Committee on Nutrition. SACN doesn't have a policy-making role. It sets recommendations for government, and government decides if and how they're implemented. But the impact of its recommendations can be far-reaching. So in terms of next steps, the current topic SACN is looking at are vitamin D requirements for dark-skinned population groups and nutrition and maternal health. Future topics on SACN's programme include protein, iodine, whole grain, iron bioavailability and omega-3. And we have another Horizon Scan meeting in June, as I said, and we'll also be looking at the dietary reference values for some micronutrients that haven't been considered for some time. So if you want to get involved, do join our interested parties list, do email the SACN inbox. You can respond to SACN requests for peer review on topics when we often publish draft versions of topics and ask for peer review. You can observe an open SACN meeting, or you can even apply to be a member. We'll be recruiting later in the year. So if you join the interested parties list, then you'll be notified of that. So that just leaves me to say thank you. I've included some links there for the SACN inbox and the Nutrition, Diet and Nutrition Survey. So thanks.
Thank you very much, Rachel. It's a lovely expose of how evidence is used to inform guidelines and how those in turn influence policy. So next up we have Professor Clare Llewellyn, Professor of Psychology and Epidemiology from UCL, from the Institute of Epidemiology and Healthcare, my fellow co-director at the Policy Research Unit. And Claire's going to be talking about regulating baby food to improve children's health. Clare.
So thank you for the introduction, Ollie. As you mentioned, this talk will highlight commercial baby food regulation as an overlooked policy lever for childhood obesity prevention. And we'll be presenting work from the Healthy Weight Policy Research Unit showing that simple label changes could support healthier feeding choices for parents. So Ollie's already kind of contextualised the problem of obesity, but childhood obesity in particular is a major public health concern. So currently around 1 in 4 children aged 4 to 5 years are living with overweight and obesity in England, and around 1 in 4 also have dental decay. Teeth decay is also the leading cause of hospital admissions for children aged 5 to 9 in this country and have been for some time. There are stark inequalities in both childhood obesity and dental decay, which are both much more common in children living in more deprived neighbourhoods. Early diet is a really important target for prevention of childhood obesity, and 1 to 5-year-old children in the UK are consuming excess calories, so too much energy relative to expenditure. And in particular, they're consuming about 10% of their calories from what we call free sugars, and this is double the recommended limit. So just to give you a bit of information about what free sugars are, they are the sugars that are added to foods and drinks in processing, so things like just table sugar, but they're also sugars released from fruit and vegetables when they're blended, pureed, or juiced. These sugars are much more easily consumed in large amounts, and therefore they contribute to these excess calories, but they're also much more damaging to developing teeth and sugars in whole fruit. To protect children from obesity and dental decay, the NHS provides feeding recommendations based on the best available evidence, but commercial baby foods, which are those that are labelled as suitable for children less than 3 years old, those foods frequently contradict this guidance, and I'll just give you some examples here. So first, the NHS is very clear that weaning should start at about 6 months of age, but many first foods are suitable from 4 months of age. Secondly, NHS advises that babies under 12 months old do not need snacks, but many baby snacks are actually marketed as suitable from 6 months of age, and this is actually the largest sector of this particular market. And third, NHS advice is that sweet foods should only be given at meal times, and this is really important for the protection of teeth against dental decay. But many sweet snacks are actually positioned as foods that babies can have throughout the day, as snacks particularly. Now, if commercial baby foods carried traffic light labels, all of these products would receive a red label for sugar. But actually, commercial baby foods are not covered by any of the regulations that cover foods and drinks for older children and adults, such as traffic light labels, but also marketing restrictions on, as well as price and placement. And this means that many of these commercial baby foods are very high in free sugars. It also means that they're able to carry a number of misleading health claims, such as no added sugar or only contains natural sugars. And these sorts of claims make these foods appear much healthier than they actually are. Despite the focus on prevention in the 10-year health plan, commercial baby foods were overlooked in that plan. However, concerns about commercial baby foods have been highlighted in policy reports from Public Health England and the WHO, and the WHO actually set out recommendations for stronger regulation of these foods, including stricter age guidance, the introduction of sugar warning labels for those foods high in free sugars, and also removing these misleading health claims from these foods. But these recommendations have never been tested in a UK context. And so the Department of Health and Social Care commissioned the Healthy Weight Policy Research Unit to test whether these policy options are feasible, effective, and also acceptable to parents in a UK context. We therefore developed a very large mixed methods programme of research on commercial baby foods. This was led largely by Dr. Rana Conway in the Institute of Epidemiology and Healthcare. We're only partway through this programme, so today I'll be presenting published work so far, including results from a survey, some experimental studies that we've undertaken, and some qualitative research with parents. So the research that I'm presenting now is research that examined whether adding sugar warning labels and increasing age guidance could actually influence, hypothetically, parents' feeding choices, so hypothetical purchasing of these foods. We conducted an online survey and experiment with just over 1,200 parents of infants aged 6 to 23 months, and they were a representative sample of the UK population, alongside focus groups of 22 parents from areas of high deprivation in London. The survey explored parents' sort of beliefs around these baby foods and their current feeding practices. The experiment tested the effect of these policy options on hypothetical food choice, and the focus groups really explored parents' kind of perceptions around these foods and their responses to these policy options. So in the survey, we found that 70% of parents believed that baby foods do not contain added sugar, 63% believe they are low in sugar, and around 60% believe that natural sugar in baby foods is not unhealthy. So these findings really suggest that many parents assume that these products that are sold in the baby aisle are healthy and that they're carefully regulated. We also looked at parents' adherence to the NHS age guidance on feeding. Only 43% of parents reported starting weaning at around 6 months, and only 12% reported avoiding snack foods before 12 months of age. So many parents are not following the current NHS guidance on when to start solids or snacks. So having kind of established what parents currently believe and what they're actually doing, we've then tested whether changing product labels could potentially influence their food choices and change them to support healthier choices. So we showed parents baby food products and asked which they would give to their child, sort of randomly varying the labels. So for high sugar dessert foods, we compared a condition with no label on the foods. We had a condition with a high sugar warning label on the products. And we had a third condition that had a high sugar warning label, but also contained one of these misleading health claims, such as kind of contains natural sugars, just to see if this undermined the effect of the high sugar warning label. We also tested stricter age guidance for snacks, so increasing it from 6 months to 12 months of age. So for the high sugar foods, without a warning label, 95% of parents chose one of the dessert products. When a high sugar warning label was added, that fell to 68%. So that's showing us that sugar warning labels could substantially reduce parents' willingness to choose these products. But actually, when we then added the phrase contains natural sugars alongside the warning label, this weakened the effect. So the proportion choosing a high sugar dessert food increased from 68% to 75%. So even when products carry a high sugar warning label, phrases such as contains natural sugar, no added sugar, these can still make them appear healthier and more acceptable to parents. We also tested stricter age labels on snacks. So when products were labelled suitable from 6 months of age, 96% of parents chose them for a 9-month-old baby. But when we then added the 12-month label, this fell to 86%. So that's a 10% drop in the number choosing those products. So simply changing the age guidance could alter parents' choices of these foods in a healthier kind of direction. One important finding was that there were no socioeconomic differences in responses to the sugar warning labels or the age labels. So that's important because it suggests that introducing label changes would be unlikely to widen health inequalities. So our qualitative work really helped to explain why these labels matter. Parents tended to assume that the products sold in the baby aisle are highly regulated to ensure that they're healthy, low in sugar, and that they align with the NHS guidance. So one parent said in the qualitative interviews of this particular product, at least when you pick it up, you already know there's no sugar in it. When we showed them that this would be required to carry a high sugar warning label, this parent was incredibly shocked. They said, if I'd known that high contents of sugar in, I would never have given that to him at 2 months, never. So parents strongly supported adding sugar warning labels to these foods and changing age guidance to better reflect NHS advice. So just to summarise, many commercial baby foods are high in free sugars. Misleading labels are making parents believe that these products are healthier than they actually are and recommended. Sugar warning labels and removal of these undermining messages could reduce intention to purchase these high sugar products, while clearer age guidance also reduces the likelihood that parents will choose snack foods for younger babies. And labelling is unlikely to widen inequalities. Importantly, parents are really supportive of introducing these labels. They want labels that reflect NHS guidance on age and sugar. Just lastly, just to mention this work has already had impact, so it helped to inform the introduction of the new voluntary industry guidelines that Rachel just mentioned that have given manufacturers 18 months to improve the composition and the labelling of products before mandatory regulation might be considered. We've collected baseline data to allow for evaluation of these guidelines in 18 months' time at the end of this period. Also, NHS feeding advice has also become clearer. So commercial baby foods are now described as products that should only be used occasionally rather than every day. And NHS advice on snack foods is now much more explicit. So they used to say that babies don't need them, but guidance now says do not give them. As I mentioned, we're only partway through a large programme of work. I've only been able to present a small amount today, but I'm very happy to talk about the ongoing work later in the Q&A at the end. So thank you for listening.
Thank you very much, Claire. A lovely example of an evolving area of policy and how we've been able to contribute here at UCL, or your team have, by filling in some of the key gaps as those needs have arisen from policy. So thank you. Next up, we have Dr. Adrian Brown, who's an associate professor here at UCL and based in the Nutrition and Dietetics Centre of Obesity Research at UCL. Adrian is also a senior specialist in weight management and a bariatric dietitian. Adrian, please come forward, and you will be talking today on weight bias in healthcare. Thank you.
One, two. There we go. Fantastic. So, good morning. I am going to be changing tacks. I'm going to be talking a little bit about weight stigma today. So, weight stigma in itself, if we think about it, are those negative attitudes, beliefs, and stereotypes that we hold about someone, about their weight. Now, this can be underweight or overweight, but today we're going to specifically talk about weight stigma in healthcare. So, this is a question to everyone. I want you to just throw out your questions. If you went and saw your healthcare provider, how would you like to feel? Happy, okay, great. Better? Safe. Reassured. Respected. These are all positive words, aren't they? So words that we've had before are optimistic, positive, hope, not feeling blamed, supported. However, when we go and speak to healthcare professionals, these are the words that come out. Non-compliant, lazy, weak-willed, dishonest, unsuccessful. You laugh, but imagine you go to see your healthcare professional and they think that of you. Would you go back? No. However, people living with obesity get this daily. So let's start thinking about healthcare. So weight bias exists in healthcare. It particularly exists in doctors and, unfortunately, dietitians, and also those specialising, like myself, in healthcare. We have two types of bias. We have conscious bias and unconscious bias. Unconscious bias is what we call implicit bias, and it's significantly high in people living with obesity. And this is confirmed by qualitative reports from patients. But this impacts on medical consultations. It impacts on whether people have eye contact. People are less likely to comply with their treatments, but also they're less likely to actually do physical examinations or measurements on the patients. And this directly impacts on the treatment of people living with obesity, and particularly women. And it's important to understand that that's less likely for people to therefore come back to their healthcare professional. So this is a review that looked at that, and they showed that it impacted predominantly on consultations and preventative screening, particularly women, where they were less likely to get smears, colorectal screenings, but also mammograms as well. It impacted on quality, as I said before, but also people were less likely to get intensification of treatments and were also more likely to be put on antidepressant medications that impacted on weight. Really showing that this impacts on people's care. But the belief in terms of healthcare can impact on behavioural factors such as physical activity. So the idea that we can fat shame, quote unquote, someone into losing weight, just give them a nudge, they need to hear the hard truth, doesn't happen. It results in reduction of activity, overeating as well. So this was the ASK study that asked healthcare professionals in terms of, firstly, their belief about the common causes of obesity. They asked general population and healthcare professionals. I want you to look at the healthcare professionals. And there is still a belief that obesity is personal responsibility. Eat less, exercise more. That's all you need to do. Nothing else. But obesity is a complex, relapsing condition. And what you'll notice when people are asked whether it is gluttony, which is down here, there's a significant portion of healthcare professionals that simply think that it's you eating too much, but also that the vast majority have emotional eating. When they ask whether it could be prevented, obesity, and we've got it in red here, it could be prevented by committing to lifestyle factors. Nearly 80% believe, nearly 60% believe that it would do, and curing obesity. It's a complex relapsing disease with biological genetic factors. How can we cure a disease? Really identifying the complexities here. Now I'm going to move on a little bit into some of the work that we've done within the centre, and this was a paper published last year that looked at weight stigma in dietetic practice. So what we did is we did some measurements of dietitians to see if they had what we call explicit bias, so conscious bias, but also unconscious bias as well. And then we asked them a series of questions about, have you experienced weight stigma yourself? So within healthcare and by their colleagues. So we got a survey of 402 dietitians in the UK. And what we found is most dietitians in UK practice had experienced weight stigma at some point in their journey. 51% before registration and nearly 60% post-registration. Nearly a quarter felt that their weight influenced their ability to actually be a dietitian. So for example, dietitians living with obesity, avoiding actually seeing people of a lower body weight, actually avoiding actually working in weight management. We found that there was explicit bias. We found that there was moderate beliefs that obesity was controllable, but also we found that there was unconscious bias. But weight stigma was across the weight spectrum. It wasn't just in dietitians living with obesity. It was dietitians living with lower body weight. So for example, the throwaway comments that come out, oh, you can eat that at lunch. So those comments that we have around food can significantly impact people's beliefs and also wanting to actually deliver care to patients. Finally, we did some qualitative work in terms of the responses, and we found that weight stigma was within dietetic practice impacted on it, the impact of weight stigma on their actual practice, and the implications of weight appearance on their job as well. And I do encourage you to read our paper for more details. So the question is, can training help? This is some data that I published with Professor Anastasia Clare. So what we did is we looked whether actual training can support and reduce down weight stigma. So we identified that actually training can help. So increasing education, so the knowledge about obesity and not being eat less, exercise more. Causal information about controllability, the genetics and social factors. Evoking empathy, having positive responses with people living with obesity as opposed to the negative responses that they have. Weight inclusive ideas in terms of weight bias awareness, and finally mixing that all together. But what is absolutely key is we address this early and we address this continuously through training. So if you're a healthcare professional, it's important that we get this information out while people are training and really put together around the genetics, socioeconomic determinants and the impacts of stigma on care. So the key factor here is also about what we say to patients. So there's initial conversations that we have in terms of obesity with patients sets the tone. Poor communication impacts on engagement, motivation, but importantly, the patient-practitioner relationship. So words that we use, so quote-unquote weight and quote-unquote unhealthy weight or quote-unquote BMI are possibly preferred, and quote-unquote obese, quote-unquote fat are least preferred terms from the systematic review data. But there's still a little bit of ambiguity regarding the best terms, and certain patients prefer certain words. So what we did is we did a large survey, this is the largest globally, asking patients about their preferred terms. And so what did we find? We found that weight, unhealthy weight and overweight are preferred terms. We found that super obese, quote unquote chubby, and quote unquote extra large were the least preferred terms. And they all had negative emotive responses in terms of how people felt. One of the key factors, and if you leave here today with one thing, it's about using the right terminology with people living with obesity. People should not be defined by their condition. So person-first language is putting the person in front of the word, in front of the condition. So it's not quote-unquote obese person, it's a person living with obesity, person living with diabetes. It's not my patient is diabetic. But if you are unsure, ask the patients because everybody is different. But we asked our patients and they said, your obese feels a slight on your lifestyle and it's your fault that your weight is in this range. If you're interested, this is the BDA guidelines that I helped to co-publish with Dr. Flint. And just to conclude, all patients, everybody in this room deserves to be treated with dignity and respect, just like people living with obesity, but at present they are not. They have respect for equal timed quality healthcare in a timely manner. We need education for healthcare professionals, both pre and post-registrated. We believe that this should be mandatory, just like other EDI training. People living with obesity should be involved in policy, but also delivery of care. Language is important, and it's important we need to think about those unintentional consequences. And I'm going to conclude with a great man and his saying. This is Desmond Tutu. If you're neutral in situations of injustice, you have chosen the side of the oppressor. These are my acknowledgements, and I thank you very much.
Thank you, Adrian. Very powerful presentation, and you've illustrated your case both with data, but also reminded us this is about decency and courtesy and good communication. Thank you. So next up, we have John Rahilly. John sits in my group. He's a research fellow at the UCL Great Ormond Street Institute for Child Health. He's going to talk on a project that he's been jointly leading with Jess Packer on developing a ready reckoner for policy work in the space of childhood obesity. Ready reckoners are rapid tools for policymakers to use to quantify the benefits of interventions. And John and Jess won the Early Career Researcher Abstract Competition, which has earned John his slot here today. So well done, John, and I shall hand over to you.
I'll wait for it to go. Here we go. Green? Can people hear me? Or? Yeah, okay. I'll apologise in advance and say you've been through sort of all the proper academics and now you come to me. So yeah, this is a project, like Ollie said, developing a thing called a Ready Reckoner, which I'll sort of discuss what it was, and it was primarily with Jess Packer, who sort of abandoned me today, which I'll hold against her forever, but that's by the by. So, if I move it on, this is a very clunky idea, but so everyone knows children are living with obesity. That number has gone up and up over the years, and there are impacts directly in childhood, and at the moment there are models that sort of look at the effects from childhood into adulthood, but there hadn't really been a focus upon child health impacts, so the impacts on children within their childhood in terms of diseases. Through the HUPRU, the Healthy Weight Policy Research Unit, there had been a project with DHSC to sort of start to bring this into focus and start to develop models that could help us look at these sort of impacts. But they lacked a tool to do it. All the tools that existed, that they knew of at least, were focused upon adult health and primarily on physical health, whereas they wanted something that could look at things in a wider context as well. So, sorry, let me go back. I realised I didn't ask a question. So they asked us to develop this thing called a Ready Reckoner, and then I'll go through what a Ready Reckoner is, and beyond being something I'd never heard of and now seem to talk about all the time. So it's a sort of, for want of a better term, a really simple indicative policy tool that's just designed to give you a very rough and ready outcome, a very quick way of coming up with something that gives you a potential impact. They're used primarily by places like DHSC, the OBR, to sort of answer big questions with simple models, but they're sort of heavy on assumptions. So yeah, not the most complex of things in some ways, but they came to us and asked if we could come up with one in relation to some work that Jess had done, and she sort of started that bit off, and then we worked on it together. So this is the sort of structure to some extent of the Ready Reckoner. We've got a definite poetic license. It doesn't quite link like this. But what we did was develop a synthetic population using Health Survey for England data and looked at ages 2 to 19. And we were able to bring in BMI and ZBMI data in relation to them. There are certain assumptions made of the data we had. There are things we had to do with ages that I won't quite go into, but I can certainly talk to people about at some point. And then we had, to be honest, Jess derived baseline prevalence in regards to 4 diseases that had been chosen in consultation with DHSC as the best ones to try and model the effects of. So that's asthma, depression, hypertension, and type 2 diabetes. And again, Jess had found risk ratios that sort of suggest the idea that the example I've put down, just to give you an idea, is asthma for children living with obesity, living with overweight first would be a 16% increase in likelihood of asthma. And then when you get to children living with obesity, you're talking a 41% increase in the likelihood of developing asthma during childhood. We converted those using log linear sort of dose response, so it's just fitting a curve to them so that we could use continuous BMI, and then we turn that into a cases prevented. I think the one thing to sort of highlight here is the cases prevented isn't if you do something now, the future impact will be this. It's essentially saying if you went back in time and did this, the population now would see this difference, which is conceptually something maybe a little hard to get your head around, but it was sort of determined by what we had access to. So we developed a ready reckoner, which is sort of often based on spreadsheets and things like that. And we decided to turn it into a sort of software approach. And one of the things we wanted to do with it was allow for different population shift scenarios. So the idea being that in the universal, you would say if there's an average effect of 0.5 shift in BMI, you just move everyone. So the entire curve shifts to the left, which means you get sort of this inevitable shift of people from healthy into underweight. And it just, all it does is move the curve. We also implemented a multiplicative approach, which is on the log. So it means it applies it proportionally. And people at the higher end would see higher changes. So it sort of shifts, it moves the curve back and it also dampens it slightly. And then the last one that we sort of implemented, and I did see Tim Cole around somewhere. I hope he doesn't see this one because he'll go, this is crazy. But we tried to use a reversion towards the UK 90. So we created a sort of synthetic, based on our cohort, a sort of what their curve would be like if it was UK 90 based, which is the sort of reference that we use. And I created something that sort of pulls it back. So what essentially it does is start to change the curve and say if it was moving towards a healthier, for want of a better term, population, this historic population, what's it do? And this one actually, as you can see, sort of creates an increase in healthiness, and it's limited. It's more at the heavy end. So the people at the heavy end are the ones that we're shifting more. Wrong one. There are a lot, I was going to say there's a lot of limitations. This is me. I'm going to say a lot of limitations. There are limitations to it. We sort of had to assume causality. There's uniform effects across the whole population. So within that, the effect we had was just for population. So we couldn't do it by different ages and so on and so forth. You couldn't break it down by sex. The other thing to think is it models BMI change rather than an actual intervention. So you need an intervention effect to model into the ready reckoner. And yeah, this steady state counterfactual is the thing I was sort of talking about, of really saying if we went back in time and did this, this would be the change to prevalence today. I'm probably running the risk of annoying the technology gods, but I wanted to try and show this in action. So pray for me here and just give me 1 sec. This will no doubt be a mistake, but let's see if we can do it. Oh, I don't know whether it's going to show it. It's showing it on the screen here, but not up there. Let me see, is there something I can do? Sorry, I knew I shouldn't have done this. Ollie warned me in advance as well, so don't blame him. Uh-oh. I've broken everything now. It's not a good sign. Okay, that's all right, that's all right. It was the risk we had. That's... Okay. That's okay, let me run back. I apologise for that. I can show you a screenshot of it that we did put in there. Oh, flip me. Oh dear. Yeah, hindsight, that was not a good plan. Okay, this is a screenshot of it at least that sort of shows you, there's a number, so you can go into an app that sort of allows you to input variables such as you can pick between a change in ZBMI or BMI itself. You can change the shift amount, and then there are these shift scenarios that you can use. So it's a sort of interactive model. It's got a technical annex on it as well. You can look at the BMI distribution plot, weight status tables. The target mean was really something for me, to be honest, so I was checking the right thing. And then there's disease outcomes, which will give you an idea of the number of cases that were prevented. Just to give you an idea, it was originally requested by DHSC, and they have used it. They used it in relation to the 10-year plan, where they were looking at modelling the effect of the new NPM on advertising restrictions. And the newer products that would come under that restriction, they modelled as having a 0.21 BMI reduction effect across children. And for that, they used the ready reckoner we gave them and came up with these cases prevented. So, yeah, sort of in conclusion, it's been used. I would like to have shown it in action, but evidently not. Yeah, I think that's probably it for me, to be honest.
Okay, thank you very much, John. Again, a lovely example of research informing policy and practice, even if we can't.
What to do with technology.
And what not to do with technology. Could I please invite all the speakers up onto the stage? So we now move to the audience participation stage. Please do think of your questions. If you're in the audience, you may raise a hand, and we have some roving microphones. I can see we have a couple of hands going up already. People who are online can submit questions by Slido. Good. So are we settled, panel?
1, 2.
Ready to go. Good. We have a few. I did see some hands. We have a hand in the middle here. We have a hand quite close to the edge. Maybe let's go to this lady here with the. Lovely. Thank you.
Hi. Thank you very much for your presentations. I have a question for Adrian Brown.
Yes.
So I provide training to local authorities on how poverty affects the body to try and deal with kind of the concept of undeserving poor within Britain, because local authorities have a big impact on that. How much when you talk about weight bias within healthcare professionals, is anybody thinking about poverty and how that is affecting people's inability to lose weight because of stress-related impact?
So you're asking about policy?
Poverty.
Policy, yes.
No, poverty.
Poverty, yes. Indeed. So we've done some work as part of a UKRI project called Fire Food. So it was looking at food insecurity in people living with obesity specifically. So we've done a lot of work specifically looking at how food insecurity is impacting on obesity, but also, so there's a lot of qualitative work, there's a lot of other work. So that is was led by Professor Alex Johnson up in Aberdeen. If you go online, there's a website, so you can go and look at that work related to food insecurity and that sort of element, very much so. But what we do know is there's a lot of intersectionality between conditions, and the experiences that people were getting when they were going to, for example, the supermarket checkout and giving vouchers, and people were looking down at them and looking. So, but also the experience they were having going around the supermarket, they were going around quick. So they would just quickly go around as much as possible. They wouldn't look at things. And when we asked them about, particularly around the idea of front of package labelling and people said if they couldn't afford it, they'll just need to close their eyes, know it wasn't good for them, and put it in their basket. So, yeah.
Thank you. I think the next question was Jenny Mindel in the middle here.
Thank you. We've heard 4 excellent presentations, but apart from the food environment, we haven't heard anything about people's socioeconomic environment, the built environment, the natural environment, transport, and many of these other things which Andrew was alluding to, things outside individuals' own control that have huge impacts on preventing and treating obesity. And I was wondering if any of the panel would like to comment.
Claire, do you want to kick that one off, and then others can come in?
Yes, there is lots of, I mean, you're doing some of this as well, Jenny, I think, but there's, as you know, there's lots of research going on into, for example, the impact of the quality of the neighbourhood, local built food environment, local policies around that as well. I think, John, you've been doing some work into that, haven't you, sort of local authority level?
Yeah, and sort of to add on, so things like the modelling stuff, the thing we've done is the sort of very rough start, and our plans are to build something that does have sort of micro level impact and can account for differences in the population and so on and so forth. Yeah, I mean, I shouldn't have come in there. I don't know what I'm saying there.
I know, I can also add, I mean, it's not my team, but there is work ongoing within the Department of Health in terms of the wider environment, but yeah, you'd have to ask my colleagues for that.
There was a systematic review meta-analysis published, I think, last year, looking at the association between different types of food outlets in the local environment and childhood obesity, I think, also adult obesity, and a greater density of fast food outlets, for example, associated with increased risk of obesity, a greater density of greengrocers, I believe, that sell fresh fruit and vegetables, associated with reduced risk of obesity. So there are a lot of different studies done in different countries that are pointing towards that as a really important factor. And I think local authorities are also interested in things like restriction of fast food outlets around schools. So one of my PhD students, Chiara Gerrica, is looking at the impact, for example, of clustering of these fast food outlets around the school area and associations with childhood obesity, linking kind of National Child Measurement Programme data and Ordnance Survey data and showing associations there as well. So I think, and then there's obviously the wider kind of commercial environment, which is not just how foods are labelled and what's on the shelf, but also marketing and advertising. And I could ask Ollie even to say a word about the advertising.
Well, I was actually going to come back on the transport issue, Jenny, because I think it's really interesting. And several years ago, there was a very famous paper in the BMJ by Prentice and Jebb talking about the balance of evidence of inactivity versus nutrition. And over the last 20 years, the evidence has shifted much more to nutrition in terms of the changes that are achievable and within the usual physiological range of humans, and that being the bigger contributor versus physical activity. But I think there's another side to it, and that's the political dimension. Was a Global Energy Balance Initiative, which was trying to push more of a narrative around physical activity, but had a lot of commercial funding from Coca-Cola and the sugar industry behind it. And I think that has hastened that transition away from the physical activity to focus on nutrition. But obviously, as you know, and transport systems have a huge role to play in people's health, both in terms of equity and other aspects of health, air pollution, social connections. It's a very rich area that we're sort of dipping into here, but you know, in some ways we can only scratch the surface with our 4 presentations. But
Yeah.
yes, point taken about the breadth of these factors and issues. Can we see some more hands? Jenny, I don't know if you can pass the microphone to the chap just to your left. And where's the other microphone? Chap in the blue shirt here. Whoever, let's take chap in the blue shirt here first, and then we'll come to you. Thank you.
Thank you. So the title of the set of talks is very grand, Turning the Tide.
Yes.
Are we going to be able to turn the tide if we're suggesting policies which might be well intended in public health terms, but might have unintended consequences for the commercial sector. And so when politicians are making up those decisions, they're being informed by evidence on the public policies on the health side. Are they also being informed by empirical work on the commercial side as well?
Yes, I think it speaks to the huge commercial influences and challenge. Yeah. And in some ways, one question I was reflecting on with you guys as a panel was the time it takes from the evidence to emerge to influencing policy. Dame Sally Davis used to say it's 18 years. It was too long. And I'm just interested in some of your experiences, perhaps particularly Clare and Rachel, because you're very much in this sort of food space and this interaction with commercial influences. And is that navigable? Can we find a sweet spot where we can make meaningful change? Or you know, is that always going to have an economic cost which would be unacceptable to politicians and the public?
It's a really good question, David. It's something that I think is a constant tension, I think, in terms of the evidence from public health policy, but also, you know, if poverty increases in the population, you also get detriments to public health from that as well, job losses and things like that. So in terms of the work that we're doing on commercial infant foods, one of the things that's on my mind, obviously, is if you increase the age label from 4 months to 6 months, then you will sell less products because there's 2 months less of a lifespan that children will eat these foods. If you increase snacks from 6 to 12 months, again, that's a year less worth of foods. What I would say is there are people doing economic modelling of the food system, people like Rich Smith, who looks at exactly this kind of issue. So things that would be of interest, I mean, what we've seen already is since the publication of the voluntary industry guidelines on commercial infant foods, which make these recommendations, industry are already responding by just removing age labels entirely from these foods. That's happening already with some foods. So that means that they wouldn't necessarily come under the voluntary industry guidelines, but they might be captured by things like the HFSS regulations. But I think the work that Rich Smith has done, and Ollie, you might know more about this than me, is that actually industry is incredibly good at adapting to policies that come in, and you don't see the large kind of decreases in revenue that they are worried about, that they're quite vocal about sometimes. And you see a shift towards healthier foods and reformulation. Part of the work that we're doing in the commercial infant foods area is there's two things. One is that we are currently mapping out, we're coding all of the foods that are currently available in the UK for sugar content to understand which ones would be required to carry a high sugar warning label, which ones are close to the threshold, so identifying areas for reformulation, and I'm sure there will be some of that, but also talking to stakeholders, including people in industry, to understand what the challenges are from their perspective, to try and identify where there could be opportunities for reformulation, product change, making these foods healthier than they currently are. So there are options out there to improve the composition of the foods without people losing jobs, I think. But it's a really important part of the work to do that economic analysis alongside. That was very waffly, sorry.
Thank you. Rachel, if you want to come in from the policy side.
I mean, I think it's just always really useful to remember that there is no silver bullet, and it's lots of different policies can, you know, chip away at it, and hopefully it'll all make a difference. And just thinking about, you know, my world in the last sort of year, we've seen some really positive changes, such as the, you know, the restrictions on advertising, things that we've been waiting for quite a while, like the nutrient profile model update. So from a second point of view, the 2015 carbohydrate report has finally made an impact in relation to free sugars and school foods. So it's sort of trying to find that balance, obviously, that you need. But I think experience of my colleagues who work in policy, working with industry, trying to sort of make those positive changes of foods can slowly make a difference.
Thank you. Shall we move to the next question? Chap here, please.
Hello. Thank you all for your talks. My question concerns the first presentation by Rachel, and in it you pointed to kind of guidance from across the world. So there was Brazil and Australia, and I was just wondering whether the kind of dietary recommendations take into account sort of seasonality and locality of food that's produced. Obviously, you know, not every food type is available all year round. Well, it is if you go to the supermarket, but sort of not if you're trying to promote local production. So I was just wondering if that was sort of factored in any way.
Yeah, it is really interesting to see what's being done globally in relation to particularly ultra-processed foods. And there are very different environments and very different sort of cultures within those countries. And in the UK, we work in a dynamic food system where there are so many different commercial influences that's different to other countries where it might be more sort of reliance on local food produce. And I think where SACN's concerned, it's more about the nutrient content necessarily in relation to the location of where the food is coming from, whether it's local, and that's for other parts of Department of Health and parts of government to think about. But I think particularly where the recommendations have been made, you know, initially the ultra-processed food definition and drive came from South America, where there was a desire to keep local food production and prevent sort of influence from the West. So I don't know whether in the UK perhaps, you know, the horse has bolted and we might be too far down the line on that one.
There's a Brazilian school food programme as well, isn't there? But I think one of the stipulations is local.
Yes, yeah. I think that's it. Yeah, a lot of international recommendations do sort of stipulate where the food can come from.
And Rachel, just to push a bit further, because food is fascinating in many ways. It touches on so many aspects of our lives, and there are other dimensions, sustainability being a key one, and that links into health too. And you can see a strong argument for why guidance should move just beyond a focus on health. What, if you're allowed to answer this question, what would need to change in government for that shift to happen? Because it has happened in other countries.
Well, I think, you know, the Eat Well Guide does take into account sustainability, and SACN, for example, is going to look at protein. So we do plan to consider the sort of sustainability issues or the different sources of protein. But yeah, strictly speaking, sustainability isn't within SACN's remit, but I think there will come a time where, you know, for example, the fish recommendations, we're also going to look at omega-3. We're aware that it does need to be looked at. We're recommending a portion of oily fish a week. Is that
environmentally sustainable? Adrian?
I'd like to just come on to that. Furthering back to our fire food work, the project looked at food insecurity and sustainability. And so when we asked people, when they go around the supermarket, whether they know what sustainability is, they didn't know what it was. They said, I can sustain my diet, one person said, not actually this is sustainable to the planet. So that definition's incredibly difficult when we transcend it outside of this environment here. And secondly, when you ask people whether they are interested in sustainability, they often say, yes, we are. But then when it comes down to cost presents far more interest to sustainability compared to probably many people in this room who can therefore choose the types of foods I know that I can when I walk around the supermarket to make it sustainable. So yes, there's these ideas that sustainability is incredibly important, but when we transcend it out into communities, it's about how reflective that is of the populations that it will impact.
Okay, thank you. Can I just check if we have any questions online before I go to the audience? We do. Shall we take an online question?
Can you hear me?
We can.
We have a question about UPFs. So, from Vicky. Is increased media around ultra-processed foods having any unintended consequences where people get less dietary fibre when they choose meat over bean burgers? So I guess unintended consequences about UPFs.
Consequences. Well, I think, there's been a really interesting bit of research published by the UKRI on sort of public perceptions of UPF. And I think what that sort of seems to boil down to is that we need more research in relation to the mechanisms. And I think what's really great about that piece of research is it sort of informed the participants along the way. And so once they are informed, they sort of think, actually, perhaps we need a bit more information to understand about these mechanisms. And the problem with the media generally and social media and ways of getting our information, there is of course a risk of unintended consequences. In particular around meat and plant burgers. Was it plant burgers?
Yes.
And not getting enough fibre from having meat instead of. I think, we sort of need to focus on the broader nutritional messaging, keep up with the 5 a day. We have recommendations around meat. I think, the plant burgers, depending on the nutritional composition of them, can form part of a balanced diet. But I think absolutely there is a risk of unintended consequences.
I think there's also some concern around micronutrient deficiency. So, for example, children get a lot of their micronutrients from fortified breakfast cereals. So the foods that tend to be fortified, marketed for children, often come into that category. Also supermarket bread, I guess.
Yeah, absolutely. We have the UK Eat Well guide that, we do currently say that things like fortified breakfast cereals and whole grain bread can be part of a balanced diet, and they do. The National Diet and Nutrition Survey shows that they contribute a significant amount to micronutrient intake. So.
Thank you. Let's go over here, and then maybe another question from online.
Sorry, Anthony Costello. Just great presentations, great team. My question really is, should you have a nasty lawyer on your team?
Should we have
a nasty lawyer? And the reason I say that, I was involved at WHO with 2 strategies taken to the World Health Assembly for endorsement. One was on inappropriate promotion of breast milk substitutes and foods for infants. One was on the child obesity strategy. The first one was blocked by the US, the UK, the European Union, and New Zealand, all the dairy producers. The second one was blocked by the US and Italy. And the reason, they don't want WHO putting out an endorsed thing that will give fuel to the lawyers in their countries to take action. So bridging the gap between the policy and politics needs nasty lawyers. I've learned that. I think WHO, because they will know where to really pinpoint the action.
Yeah. It's a really interesting observation. I was lucky enough to study in the States, and one thing that really struck me there was how integrated law was within their public health department where I was studying. Do you have any friendly laws in mind for us?
That's what I was going to ask, yeah.
There's a scary law at Liverpool somewhere.
There are loads of nasty lawyers around. You could, actually, if you walk down to Doughty Street, there's a whole group of them there who are really nasty.
With a banner, yeah?
Yeah, exactly. And some of them will do it relatively low cost. Not many, but...
Yeah. Lovely, thank you. Sorry, I said again online next. Do we have any online questions ready?
A question about parental dietary behaviour. So, is there evidence that parental dietary behaviour has a measurable impact on children's long-term food preference?
Clare, this feels made for you.
Is that parents' own dietary intake?
That's how I've interpreted that.
Yeah, there are, yes. So you tend to see diet quality kind of cluster within families. So the diets that parents tend to follow themselves are often the diets that their children end up following, partly because they're the foods that are brought into the home. If you're eating with your child at meals, then they're the foods that children are offered, and they become the norm. And we know that there's very strong research to show that the foods that children consume very early in life, even in the first kind of couple of years, dietary patterns track sort of over time, moderately. So the foods that you tend to be introduced to when you're very young tend to be the foods that you quite like when you're older as well. So shaping those preferences are quite important in early life.
Thank you. A chap over here.
Thank you very much. Franklin from Oslo, Norway. My question is, in the context of public health, do you think housing deficit has in any way influence over choice of ultra-processed food consumption for young adults and households? Thank you.
So can I just check the question? Was it about housing deficit and its
Yes.
influence on UPF?
Yes, whether it affects access of households and young people to, whether it affects their intake of ultra-processed foods.
Okay, and by housing deficit, are you seeing that just as a measure of socioeconomic status, or that's a lack of access to kitchens to prepare fresh food?
Yes.
The latter.
Yes, I want to see if there are studies or whether we have actually been looking at that as a social factor that influence access to.
I don't know if my colleague Jessica Sheringham is in the audience, but I know that is something I perceive to look at. Adrian, you would like to come in.
Thank you very much. So we have done some work with people experiencing homelessness in temporary accommodation. We did diaries across 200 participants looking and coding for ultra-processed food. And when we looked at it, over 60% unpublished data was from UPF, and the highest quintile went up to 90% UPF. And in part, when we did some further work before that, looking at access, often when you speak to people experiencing homelessness around access, when they go into certain temporary accommodations have ability to cook, some simply do not have it, and those areas can at times be not very nice to cook in. So they might have a kettle that's broken, they might have a fridge, it's not working. If they put food in there, it's taken. So it ends up with also the food that is given to hostels that might offer food tends to be from an ultra-processed idea. It tends to be long shelf life. So yes, we do have data. We're in the process of submission for publication,
I could also comment on a project I'm involved in called the Family Food Experiences Study London, which is a kind of complex systems project which involved some very in-depth qualitative, more like ethnographic research with families living on very low incomes in the London area. And this is led by my colleague Christina Vogel at City University. And some of those families were kind of family of 5, 6, 7 people living in perhaps 1 or 2 rooms in a shared house with a shared kitchen. And those families would talk about, for example, feeding their children cereal for dinner because they can't use the kitchen. The parents also have complex lives and they're working lots of different jobs, and it's something they know is safe and has a long shelf life, and the kids can get it themselves. So I think that's a big factor. We also did some research in the Gemini cohort, which we host here from UCL, on just looking at socioeconomic patterning of specifically ultra-processed food intake in toddlerhood, 21 months, and then again at 7 years of age. And there were, in the kind of expected directions, there were socioeconomic differences, including income, occupation, and education. But interestingly, the most important factor was maternal education, which I don't know, we need to get to the bottom of that, but these are really important factors.
Okay, thank you. So we need to draw this session to a close, unfortunately. I've really enjoyed this lively discussion, so thank you, panel, thank you, audience, and those online for your questions. And I shall hand back to Graham.
Thank you very much. A superb session, and thanks, Ollie, for chairing it. We now go to lunch, but there is an opportunity during lunchtime to visit the early career researchers' posters, which are downstairs in the low ground floor meeting room next to the winter garden. So please take the opportunity during your lunchtime to have a look at those posters. We're really proud of our Health for Public Early Career Researchers Network. They do an amazing job, and for those of you online, I think you can also see the posters online. So there's an opportunity there. Could you please rejoin us at 1:20 for our session tackling alcohol and smoking harm. Do enjoy your lunches. Thank you very much.